Então, boa tarde a todos. A gente está hoje à tarde aqui com o Dr. Paul Carpenter, que é chefe do Serviço de Transplante Pediátrico do Fred Hutchinson em Seattle, e com a doutora Adriana Mello, que é médica hematologista pediátrica do Hospital Pequeno Príncipe e do Hospital Universitário da Universidade do Paraná. Ela trabalha, assim como eu, com DECH em pediatria, então hoje a gente vai conversar um pouco com o Dr. Paul sobre doença do enxerto contra-hospedeiro crônica em crianças, o que a gente pode fazer melhor e quais são os nossos desafios até o momento aqui no nosso país. Então, good afternoon. Thank you for staying with us these few minutes. Like to start? What do you think?
Yes. We would like to know what are the major difficulties do you have for diagnosis chronic GVHD in pediatric patients?
So I think the biggest difficulty is, starts with the history. So the patient, if they're pre-verbal or not very verbal, they don't explain their symptoms the same way an older child or adult would. So if you don't do a detailed history with the parent and a detailed exam, you may miss things. So a child may refuse to eat food or do things, but if nobody looks in their mouth, you may miss chronic GVHD of the mouth. So there's the fundamental problem is you have to look everywhere and ask enough questions of somebody, usually the parent, to try and really find out whether they have symptoms of chronic GVHD. The NIH is working on, an investigator at the NIH is working on a symptom scale like the Lee symptom scale for children, and that will be helpful once that gets completely validated. So beyond the history, the exam, again, you've got to look head to toe, you've got to check their range of motion, and then you get into the problems of how cooperative the child is, which is just general pediatrics. So you have to make it fun so that you can assess their range of motion. For example, the biggest areas you don't want to miss are sclerosis and fasciitis, which leads to the joint problems. And then the lungs, we talked about that a little earlier today, but children can't reliably do PFTs below age 7. Sometimes you can get a good 6-year-old to get spirometry. So the sooner we can get better measures of lung function, like handheld spirometry maybe, or multiple breath nitrogen washout testing can be used down to about age 3. There's a study from Vancouver, British Columbia on that. And then you have to move to more radiological methods like xenon MRI that Cincinnati does, and various other approaches. So those approaches, how relevant they'll be for the global scale, because obviously an MRI is very expensive, but it would be nice to get the simpler measures to measure lung function. So those are the main difficulties, I think, with diagnosis.
Talking about lungs yet, when you do the biopsies, pulmonary biopsies?
I would say mostly not very much anymore. Even in my adult patients, if there are obstructive changes on the PFTs that are irreversible, so they don't respond to bronchodilators, then you have a high suspicion for bronchiolitis obliterans. So long as there's no infiltrate on the chest X-ray or chest CT, you probably don't need a biopsy. If they do have an infiltrate, you would start with a BAL, and then you can make a decision. If the BAL is negative and they have obstructive PFTs, we mostly don't do a biopsy. If they don't respond to treatment, then we might have to worry about rarer forms of lung GVHD, like interstitial lung disease or those sorts of things. And then we usually involve pulmonary consult, infectious disease consult, and we make a joint decision about whether to do a biopsy.
And when you do this diagnosis of pulmonary chronic GVHD, do you think about starting corticosteroids 1 milligram per kilo or do a pulse therapy?
So if they have obstructive changes and you think it's bronchiolitis obliterans, the mainstay of treatment is actually inhaled, high-dose inhaled corticosteroids like it is for adults. And we rarely use steroids.
Systemic.
So, but often the lung GVHD is occurring in the setting of other GVHD. So if it's occurring in the other setting, then they may get some steroids for that, prednisone. But if they have isolated bronchiolitis obliterans, we will just add the inhaled aerosolized steroids plus azithromycin and montelukast.
Okay.
And if they have restrictive changes like cryptogenic organizing pneumonia, then they get generally 0.75 milligrams per kilogram, going up to 1 milligram per kilogram if they have an oxygen requirement or they're massive pulmonary infiltrates. But for the lesser severe cryptogenic organizing pneumonia, we will start with 0.75 milligrams per kilogram. And then a slow taper on a daily basis over 3 to 4 months.
Okay. And for sclerosis, do you think there is a better option for add to corticosteroids for treatment?
I don't. So you need to add some amount of steroids, whether that's 1 per kilo or 0.5 per kilo or 0.25 per kilo. It depends on how much inflammation I'm seeing. Because if there's not a lot of inflammation, the steroids just cause weight gain and they make everything tighter, and then you're pinching the skin, and it's a lot of it's steroid toxicity. So I will only add high-dose steroids if they've got a lot of inflammation, a lot of edema, that then turns into fibrosis if you don't treat it. So I'll add that. As far as picking which steroid-sparing agent, I will usually jump to one of the newer agents. And so my first line would generally be, if they're on a calcineurin inhibitor and they get sclerosis, I'll switch that to ruxolitinib. If they fail that, then I would switch to either belimusitol or ibrutinib, depending on the age. So if it's a 4-year-old, ibrutinib has a liquid formulation, so I would use that. If they're 12 years old, I will use belimusitol.
Yes. And for skin, do you think that it's better than photopheresis?
No, I think... So thank you for reminding me about that. Photopheresis is certainly a good option, but it's very inconvenient. You usually have to put in a central line, and if a patient and a family has a choice of taking a pill versus committing to months of photopheresis therapy, I know what I would vote for in that situation. And remember, at least in the Jakafi and the ruxolitinib trials, ECP was one of the things in the best available therapy. So you can't, the study was not designed to say which one of those things, as an individual group was better or worse, but we know that the best available therapy group was not better than ruxolitinib. So I think that's reasonable to say that, you can use ruxolitinib before the other ones. And if their child lives a long way from the center and they have to drive 3 hours to get their photopheresis, that's also a problem.
Yes.
So I usually use ECP if they've failed these other things.
Okay.
Do you use ECP for acute GVHD also or not?
Yeah, particularly if they have simultaneous infections, because I don't want to over-immunosuppress them. Now there are some practical problems with ECP for steroid refractory acute GVHD, especially if their platelet count is 10 and their hemoglobin, they're bleeding from their gut. So that makes it challenging, and then you have to anticoagulate them from the machine. But I do think it has its place for those patients where you don't want to add increased immunosuppression that will make everything, more infectious-wise a risk. So I think it can be useful.
And talking about a little bit tapering, immunosuppression, once your patients, you are not hear me, I'm sorry.
Stable, quiet.
Stable or complete remission, we can say that. What's your steps to taper?
So it depends on how much prednisone they're stable on. So if you started high and they're still at 0.5 milligram per kilogram, so say the patient weighs 40 kilograms and they're on 20 milligrams of prednisone. If everything's stable, I might decrease that by no faster than like 2.5 milligrams, so a half of a 5 milligram pill. Sometimes I might just go by 1 milligram, but I'll do 1 milligram every week or every 2 weeks. And then until I get down to physiological doses of, the equivalent of, say, 4 milligrams of prednisone or 5, depending on the size of the child. Maybe sometimes it's only 2. And then once they're on physiological prednisone, I'll either convert that to hydrocortisone if they're adrenal insufficient, or I'll just taper off. And then I want to see everything stable for at least a month before I try to do the next agent. And then it depends, if they're chronic GVHD, it really depends. If they've only had 6 months of chronic GVHD therapy and they had a mismatched bone marrow transplant, then that's too soon to taper. I'll wait another 6 months to a year just on their single steroid-sparing agent.
And what's the advantage to...
Especially in a non-malignant disease.
Yes.
If they have a malignant disease, there's the pressure to try and get them off. But chronic GVHD is also associated with decreased relapse.
We need to find the immune tolerance.
Yes.
When you have pulmonary chronic GVHD and in a patient that have malignant disease, do you use azithromycin?
Do I use
azithromycin for them?
azithromycin?
Yes.
Yes.
Because there is the
concern about relapse?
Yes.
Yeah. I think bronchiolitis obliterans is very concerning. So of the FAM therapy, fluticasone, azithromycin, montelukast, the first one to be removed is the azithromycin. So I do it, but in a malignant disease, I will get rid of that after everything's stable, and then just leave them on the montelukast and the fluticasone. But in the beginning, if they've got their FEV1 doing this, you've got to try and get that under control. And since we don't use a lot of prednisone for bronchiolitis obliterans, we want to maximize the other therapies.
Do you have an personal opinion about the pulse, the steroids pulse? I just asking because we have a group in Brazil, a pulmonary group, that use this kind of approach in other disease, and we are doing that in pulmonary GVHD for some patients because the access of other medications.
So 10, like when you say pulse, 10 milligrams per kilogram?
10 or to 30.
To 30, yeah. So Minnesota used to do 10 milligram per kilogram for just chronic GVHD in general. I think honestly, if you have to use that, that's a desperate measure. The inhaled, the best data is from the French group, Anne Bergeron. I mean, it's powerful. The inhaled, these are high potency fluorinated steroids that are going directly into the lung. That is, I think, a much better approach.
But it's IV, huh? It's IV, 3 days IV, no?
No, the fluticasone, it's inhaled.
No, but the pulse is...
the pulse is, yes, but I'm saying inhaled,
yes, the
potent,
difference, I mean.
more safe
more
than,
safe, okay.
yeah.
Safer, okay.
Right. And I've never had to use the pulse. When my patient's in the ICU and they're on a ventilator and they're looking like they're going to die, that's when they get the pulse. Because
maybe I will stop.
Well, no, but I think the point is they don't usually get there. So you're
Yes.
saying if you use it before, they don't have the problem.
But the rationale, I don't think that's about efficacy. It's more about adverse events because between the pulse, we can give physiological dose daily or each other day.
Yeah.
So
Do
it
you
was
use inhaled steroids though?
Also.
Also.
Yeah.
Yeah. How do you know you need both?
Maybe I know.
Yeah. In my experience with adults, because I treat 1-year-old up to 80-year-olds, 10 per kilo of steroids is a lot. 30 per kilo is, I mean, even if you just do it once a week, you imagine how much that cumulative dose of steroids is going to be. Even if you pulse it,
Okay.
they're going to have problems with their bones and everything else.
No, it's very interesting your thought because they think differently.
How many
Yes.
weeks do you do the pulse?
6 months,
So when
3 days per month.
of 30 or 10?
In many patients, majority 10 per kilo
Yeah.
per day, 3 days, so 30 per.
I would like
per
to see
month,
the data,
yes,
but
yes.
when Minnesota did,
Yes.
we were going to do a steroid taper protocol. And when I added up all the cumulative dose of steroids of the Minnesota 10 milligram per kilogram pulse with physiologic in between each week, after 6 to 9 months of therapy, it was the same cumulative
okay,
dose of
okay.
steroids.
Okay.
And, you know,
interesting.
I realize all centers have their dogma. Seattle used to say you must give steroids every other day. That's not true. Some patients, you have to give it every day. And so I don't think there's one perfect answer. I'm not saying the pulse is wrong, but I would want to see a trial before I said that that was the better approach.
Okay.
Yeah.
Very
Do your
good.
patients get Cushingoid?
No,
Okay.
no.
So maybe it's a good thing.
Maybe it's a good thing.
But you're not going to be able to
But
say
I
whether
d-
it's
I
better
don't
than
think
than inhaled.
We have number to
Yeah.
say that, but they have publication in other disease. That's
Yeah.
why they were proposing.
You really need pulse plus inhaled, and inhaled only to determine
yes,
whether it adds value.
that's interesting. So it was a real pleasure to have you with us. We are running out of time.
Oh, okay, sure.
Yes.
It's been a long time. All right.
I would like
yes.
to.
We
to
have a
stay
lot
with
to
you.
ask.
Yes. All
But
right.
have to
tomorrow
finish.
morning we are with you.
More
so
questions.
we are going.
All right. It was fun.
Thank you
Thank
very
you.
much.
You bet.